Next, we have Dr. AFSANA. She'll be presenting on role of supplemental laser following anti-VEGF in management of zone 1 ROP.
Good evening, everyone. Myself, Dr. AFSANA from Lady Hardinge Medical College. Today, I would like to present on the topic role of supplemental laser following anti-VEGF in management of zone 1 ROP. I have no financial interest. As retinopathy of prematurity is a vasoproliferative disorder in preterm infants, its incidence in India is reported in between 38 to 52%, which is a major cause of preventable blindness in preterm infants. So my study rationale is based on combined versus monotherapy. Traditionally, monotherapy was considered as a mainstay of treatment in aggressive retinopathy of prematurity, but it has potential advantages and disadvantages. As laser monotherapy can lead to permanent regression of the disease, but the disadvantage it can cause high myopia and large amount of field loss. Similarly, with the anti-VEGF, it can lead to quick resolution of the disease, but it has potential for late reactivation, prolonged follow-up, and persistent avascular retina. So with the introduction of combined therapy, that is anti-VEGF plus laser, it has led to greater structural stability, fewer recurrences, and fewer follow-ups. That was also reported by various authors in the literature. So as we know, the combination therapy is more effective than monotherapy in AROP, but the timing of the laser post-anti-VEGF is not decided. It is questionable. If we do early laser, we need more area of retina to be lasered, thereby limiting the field of view. But if we do late laser, it can lead to reactivation and rapid progression of the disease. So timing of the supplemental laser is not standardized here. It ranged from concurrent laser to 16 weeks as reported in the literature. So my primary objective was to assess the need and timing of the laser following anti-VEGF therapy, and my secondary objective was to identify the factors associated with laser requirement and to evaluate the adverse effect post-combination therapy. It was a prospective observational study done in between November 2022 to March 2024. I took 30 eyes of 15 neonates. My inclusion criteria was zone 1 AROP treated with anti-VEGF, and my exclusion criteria was stage 4 and 5 ROP with other retinal disorder. So just to summarize my study protocol, I took zone 1 AROP of 30 eyes of 15 neonates treated with anti-VEGF. I did weekly follow-up of those neonates and monitored for the signs of reactivation, resolution, and progression of the disease. At the same point of time, we divided them into two groups. Group A, in which the reactivation was observed and laser was done. Group B, in which no reactivation was observed and just simple observation was done. My outcome analysis was timing of reactivation, risk factor analysis, and refractive error assessment. These are my demographic data. We took the neonates ranging from 27 to 31 weeks of gestation age. These are the risk factors we analyzed, and my outcome was we reported 8 out of 30 eyes undergone reactivation, among which 4 eyes reactivated at 7 weeks post-anti-VEGF, and remaining 4 eyes reactivated in between 7 to 10 weeks post-anti-VEGF. And a significant association of the reactivation was found with small for gestation age, that is less than 28 weeks. Similarly, a significant association was found with prolonged duration of CPAP, which was also observed in group A, and poor weight gain was also observed in those neonates. But no association with these risk factors was found in my study. So key findings of my study was reactivation was observed in 8 eyes, that is 26.6%, approximately 1/3 of our sample size that required laser supplementation. Mean time of reactivation was 7.5 plus minus 0.57 weeks. That helped in optimizing the timing of laser following anti-VEGF therapy. And the main risk factors reported, number 1 is prolonged CPAP duration, poor weight gain, and low gestational age. Refractive error was present in 75% of the laser-treated eyes, and persistent avascular retina was reported in 81.8% of the non-laser-treated eyes. So anti-VEGF therapy is effective, but it has potential for late recurrence that necessitate close and longer follow-up. So just to conclude, combined therapy improves the ROP outcome. Early detection of these risk factors may help in optimizing the treatment timing, and there is need for standardized guidelines on the timing of supplemental laser to balance benefits and risks. My limitations were the sample size was small, that limits generalizability, follow-up duration may not capture long-term reflective outcome, and future goals, there will be need of large multi-center trials, long-term follow-ups, and biomarker studies to evaluate which infants are at higher risk for reactivation. Thank you.
Thank you very much. The question to you is these peripheral avascular zones that you're monitoring every week, there could be some cases where there's no reactivation happening week on week.
Yes,
So
sir.
is there going to be a threshold of a time where you have to take a decision that these patients have to be lasered now? Or will you wait on for further? I mean, what is the age limit till which you have
Sir,
to do the laser to the?
see, sir, we took a time for follow-up up to 10 weeks. At the end of 10 weeks, we analyze how much retina is avascular. So in most of my patients who are non-lasered, 3 disc diameter retina was avascular, but we did not did any intervention. On long-term follow-up, we found that retina is also vascularized.
No, a certain percentage of babies will still have persistent avascular zone even beyond that time. So then, do you do laser to them even if there's no reactivation? Is the question.
We did not did any laser to those sides.
For how long did you follow them up?
In my study, we followed up till 10 weeks, post anti-VEGF.
So first you are giving anti-VEGF to all the patients.
Zone 1 AROP, anti-VEGF within 48 to 72 hours.
Okay, and then you are doing the laser.
No, ma'am. The first.
Deactivated case.
Yes, ma'am.
Right. So, okay.
Thank you.